Yeah, he's getting it live streamed and all.
No, I think he's traveling. So he said Bashir will.
Okay, okay.
Sriman, are you there? Sriman.
We will wait, I think. We don't
Yeah,
know.
it was
We'll
only
be here, yeah.
10 participants, no? So
Yeah.
5-10 minutes.
Today, with which society is doing this program?
No, it's not the society. It is like whoever, like many people called up that they want to be part of this program. So they have taken the numbers and started this empty program.
Okay, but today we are speaking on that module, na, where I have to start with wow overview.
No, violence against doctors. This is.
Yeah.
That is the one. Not the online certification school program. It's not that.
No, it is violence against women and overview, then approach to women, effects of wow on pregnancy. We are taking this.
Yes,
yeah.
Exactly.
I'm taking first talk. Yeah.
I don't know.
Yesterday was too good.
Yeah, I know. 331.
I read, I said, wow, great.
But the only thing is now we should look forward that these 313 at least,
yes,
one school each or 3 schools each, then I think we will cross our target.
Very true.
Yeah.
Hello, Dr. Jamuna, Dr.
Hi,
Lakshmi.
Pooja. Nice to see you back again.
Yes. Ma'am, I had a query about yesterday. Can I ask you?
Yeah, why not?
Ma'am, actually, I'm a associate professor and I'm teaching in Lady Urban College also. So it is like I wanted to ask you that this program that I attended yesterday, can be extended to colleges also? Because it is like the colleges, the target group would be they fall into age group, they start from 17 onwards.
Yes.
So I was, is it possible or is it only confined for schools?
No, see, basically now we are targeting only 9th, 10th and 11th, 12th.
Yeah, that's what I have.
Probably in future we can extend to the college because it's very much needed.
Yes, ma'am. And ours is a girls' college.
I know. The drawback is if we do for the college, we can do the program for the college girls or the boys, but they won't get the certification. That is a drawback.
But even like probably, ma'am, if you could ask, I work very closely with Dr. Anita Sabharwal. So at times, these public lectures, you must be knowing Dr. Anita Sabharwal from, So it is like, so if it's possible, we can do even without certification, or maybe we can have a different format or something, because this would be very useful for these girls.
Correct.
And especially because now they've just stepped out of school and then they've come out of their cocoons and so rather it is more needed for them because they are on their own in the first year and everything. So that way.
Yeah, agree. 100% agree with you, Pooja. So we are trying to come out with maybe we have to get some little modification in this.
Yes, ma'am. Little modification we can do. And maybe the certification procedure can change. We can have it customized for colleges. A little bit, little change kar denge, not really Dheera ke through. Maybe we can just do it a little bit the way we do it for other conferences and everything. The format would remain the same. Everything would remain the same. But we can speak to ma'am and we can see what modifications we can do.
We can bring about modifications in the module.
No, yes.
It will be only Dheera initiative.
No, that's what I'm saying. It will be Dheera initiative, but we can just modify it a bit in the certification part. Correct. It is like so that we can include the colleges, especially the undergraduate colleges.
And even medical colleges also.
Yes, medical colleges or any college for that matter.
That's true.
Yeah.
I think this will put forward to Ajay also. He is the mastermind behind, and Dr. Shanta. Anyway, we also have told the same thing as you expressed today. We were saying that yes, we want to, it's better we do even for the colleges.
Yes, because पता है school में तो फिर भी parents control is there. You know, parents are more vigilant. When they come in colleges, many of them, they go to hostels, and many, because I see we have a hostel, so many, they've stepped out of home for the first time. They need to be empowered with these life skills.
Yeah,
So,
very true, Pooja.
and I really loved that bystanders role yesterday. It was lovely. It was like so many things I also didn't know. And I'm also working like as adolescent health counselor. Since with Dr. Sharda and everything, still I learned so many new things yesterday. It was very nice. Thank you, ma'am.
So our president also is there with us, luckily.
Yeah.
So
I can see Shanta, yeah.
Yes, I think we are fortunate to get her today.
Hi, Jamna.
She's still traveling, not in the flight, maybe in the
In the car, I'm going to the Cochin airport now.
Hi, Kiran.
Hi, ma'am. Good afternoon. Good afternoon, Shanta ma'am, Lakshmi ma'am.
Good afternoon.
We are just waiting for some more participants, Shanta, because
yeah.
has come in. So just
Okay.
Can imagine that.
Someone was talking about bystanders.
Yesterday, Pooja,
that was really very short PPT in our module, but very, very useful and very practical. The 5 days.
Today, Shaijas also was telling in Kannur, the girls and everyone was telling that one girl, after attending the program of this active bystander, she had helped to save a girl whom she found injured. So she was also telling that that's so useful.
Yeah. So the basic thing is violent perpetrators are less and the bystanders are many. So the role of bystanders is more. And
I think students are liking that decoding the peer pressure also. And bystander role. These two things they really enjoying, and they're coming
very, very practical and
And even the lecturers and the teachers, they also are appreciating those two modules. Just now, Pooja was telling Shanta that she is associate in Lady Harding College.
I'm not in Lady Harding, I'm in Lady Irwin. Lady Irwin, yeah. So this is different from Lady Harding, and it is like, and this is a home science college rather, and it is a premier institute of Asia. It is like, and I have worked with with Professor Shanta ma'am. It is like earlier when we had that workshop on contraception and all, a lot of these initiatives I've in these public lectures we've taken part and all. So it is like that's why I was saying that especially when it is not a medical college, we should extend it to other colleges, because this is much more required for colleges as well. And instead of confining it to schools like 9th, 10th, 11th, 12th, and we must extend it to colleges.
That is her input.
Yeah.
So I said we are working for it. Let's hope that it comes out. Yeah. Sriman, are you there or Bashir is there?
Bashir is there.
Okay. Because Sriman is set in. It is 3:40.
నేను log out అయితే Jamna తర్వాత Kiran I log out. Okay?
No, you address these people at least. There are 22 people.
I know, it's very happy to see all of you get the master training done, but kindly see that you all do the course in some schools. Each one, at least 3-4 schools will make a big difference. That's the most important aspect of this master trainers.
Okay, thank you, Shanta.
Okay.
Thank you for joining.
I'm too tired to talk. Sorry.
I know you are tired.
Okay.
So take care. Huh? Have a safe trip.
Back.
Bye.
Okay, bye.
Okay. Probably Lakshmi, we can start.
Yeah, I think so.
Bashir.
Good afternoon, Jamna ma'am.
Hey, good afternoon. Madhavi is very, very excited and she's taking so much of effort. Already we have done one college in Padmaja. We did one in a junior college and one in school, and one more junior college we are going to do. So I think she's roping in almost 3 to 4.
That covered almost 1100 students, ma'am.
Yes, I know.
Yeah. Yes,
so far, that's really impressive.
Under your guidance, ma'am.
Oh, no, not. It's the effort of everyone.
Very true, ma'am.
Otherwise, we can't reach. Shall we start, Lakshmi?
I am ready whenever you say.
Yeah, because it is 3:45, almost 3:50 now. Almost 20 minutes.
How many registered for today?
Now 20. Bashir, how many are registered till now? Bashir, how many registered? Bashir, are you there?
It shows 21 participants, Dr. Jamna.
I know, but YouTube also we get, no? That's why I was.
Okay.
Registration need not be the same as who have joined.
9.
Yeah.
69.
69.
Then we can start, Lakshmi. Yeah, you can start.
You give your opening remarks, Dr. Jamna, and then afterwards I will start.
Okay. Good afternoon, all the participants today. We really appreciate for sparing your valuable time on a Sunday, and that too between 3 and 5. And this is a topic which is very, very important for all of us, because violence against women and doctors is being so much, and we are the ones who, are the people of point of first contact for that woman. So we can do a change and help and support these women who come to us. So with this vision and mission, this program has been formulated, and so many doctors have given their time and made these modules. And I think we should really thank everyone. So we'll start with these modules, and Lakshmi will take the first one. Thank you, Lakshmi, for joining.
Yes. Are my slides visible?
Yes.
Yeah. So
yes.
I am the correct slides. Yeah. So very good afternoon, one and all. Today I am the opening batsman, and I am speaking on violence against women, that is an overview. And these are our contributors who have prepared this presentation. So I thank each one of them for giving us these wonderful slides and giving us an overview of violence against women. Friends, gender-based violence is the most pervasive yet least visible human rights violation in the world. Now, I want you all to be interactive, and you have to put your response in the chat box. What forms of gender-based violence are experienced as women and girls? put your response, and I'm sure Dr. Jamna, you are there. You can see who is responding so that we can answer. Where can women and girls experience gender-based violence, and which age groups may experience gender-based violence? So I hope you all have put your responses in the chat box. Now, what do we actually understand by violence against women? Friends, violence against women means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. So this is what we mean by violence against women. Violence against women encompasses all these things, but it is not limited to physical, sexual, and psychological violence. Can be from family, community, or it can be perpetrated or condoned by the state wherever it occurs. So what are the types of violence? It can be physical, psychological, or sexual violence. Physical, we all are well versed with. We get so many patients, kicking, biting, slapping, beating, strangling. These are just a few examples of physical violence. Psychological violence can be in the form of preventing a woman from seeing family and friends, belittlement or humiliation, economic restrictions, violence or threats against cherished objects, and other forms of controlling behaviors. Again, the list is endless. Sexual violence can be in the form of forced sex using physical force, threats, intimidation, forced participation in degrading sexual acts, denial of the right to use contraceptives or measures to protect against sexually transmitted diseases. Remember, intentionally inflicted injuries are often disguised as accidents, and many women, pregnant women, they just don't volunteer that it has been an injury. They all say that it is an accident. At times, women are seriously injured, and in some cases, they die as a result of these injuries. So this is the prevalence rate of intimate partner violence, which the data has been given to us by WHO in 2010. So the intimate partner violence, it is physical and or sexual violence by an intimate partner in their lifetime. And just go through the statistics. It is in India, it is 28.8% of women, they suffer intimate partner violence, because it is more rampant in Afghanistan and Bangladesh, but we are not lagging behind. Remember, it is just the tip of the iceberg. Gender-based violence in majority of the cases is underreported. 40% of women who experience gender-based violence, previously they disclosed to someone, but only 7% they report to a formal source. The cycle of abuse continues, starts from child, when she is a child, infancy, pre-birth, and the adolescence. In pre-birth, we all know that it can take a form of sex-selective abortions, the effects of battering on pregnancy and childbirth. Infancy, again, in some states, female infanticide is still rampant, and physical, sexual, or psychological abuse can occur when she is just an infant. When she is a child, then again child marriage is prevalent in some states. Female genital mutilation, though less, but it is also there in India. Physical, sexual, and psychological abuse, incest, child prostitution, and pornography. So when she is young, she can be subjected to all these forms of violence. when she is an adolescent girl, she faces the risk of trafficking, honor killing, partner violence, marital rape, dowry abuse, murder, abuse of women with disabilities, rape, sexual harassment, forced prostitution, pornography, and forced pregnancy, acid throwing attacks, economically coerced sex, incest, sexual abuse in the workplace, friends. The list can go on and on. There are n numbers of forms which can a woman be subjected to physical, psychological, or sexual violence. Remember, these million women globally are married before 18 years. 50% of child marriages, they occur in South Asia. 125 million women in 29 countries in Africa and Middle East, they experience female genital mutilation. 1957 women in Pakistan were killed in the name of honor killing between 2003 to 2007. 11.4 million women, they are trafficked globally. 30% women, they experience intimate partner violence, and 7% are sexually assaulted by someone other than the partner. So you can see that the prevalence is huge, huge, and that is why Dr. Shanta has started this initiative and she has come out with this wonderful module. So why we are so much worried and bothered? Because this gender-based violence, it definitely has health impacts on that individual. And this health impact can be on physical health and it can be on reproductive health. On physical health, the acute physical aspects, the impact of injury can be in terms of injury, shock, disease, infection, weight loss or gain, regressive behaviors, and not eating or eating all the time. But gender-based violence can have chronic impact on this individual as well in the form of disabilities, chronic pain, gastrointestinal disorders in the form of irritable bowel syndrome. She can have eating disorders, sleep disorders, and chronic fatigue. Gender-based violence also impacts the reproductive health of that woman. It can be in the form of miscarriage, unwanted pregnancy, unsafe abortion, sexually transmitted infections including HIV, menstrual disorders, pregnancy complications, and gynecological disorders. So you see, it impacts every aspect of that woman's life. Now, there are effects beyond the individual survivor. So, there are effects on children of women who experience abuse in terms of high rates of infant mortality, behavior problems, anxiety, depression, attempted suicide, poor school performance, physical injury or health complaints, experiencing or perpetrating violence as adults. So these are all collateral damages. It is not only the woman who suffers because she is subjected to violence, even her children suffers. There are effects of this gender-based violence on her family in the form of fractured family relationship, safe care if abuse happened in the home, then this is compromised. Co-occurring violence, mother ने अपना गुस्सा बच्चों पे निकाला, कहीं और निकाला frustration, and poorer collective health and coping. This gender-based violence on that particular woman also has effect on community and society. Because if a woman is subjected to gender-based violence, then the cost of services incurred by victims and families has to be borne by the community and society. Loss of education and potential development and contribution by child as they become an adult, perpetuation of violence in community in general, and higher crime rates, burden on safety and justice sectors. So in these two slides, I have tried to tell you about the impact of gender-based violence on the physical, psychological, and reproductive health of the woman, and not only on that woman, how it affects her children, her family, and community and society at large. So where and how do violence and HIV/AIDS intersect? This is the slide to tell you about this intersection. direct transmission through sexual violence that leads to sexual exposure, presence of other STIs or degree of trauma. This leads to indirect transmission through sexual risk-taking violence is linked to increased risk-taking and multiple partners, non-primary partners, all these are linked to STI prevalence. Indirect transmission through inability to negotiate condom use, because if the woman is under threat, she just can't negotiate, she just can't insist that the male partner has to use condoms. Women find it difficult to suggest or insist on condom use in face of or threat of violence. So whenever there is a forced sex, woman is not in a position to negotiate for safe sex. This all leads to more prevalence of sexually transmitted infection and HIV/AIDS. Now see this slide where the intimate partner violence, I have already told you that physical trauma, injuries can be in the musculoskeletal system, soft tissues, there can be genital trauma and other body parts injury as well. The psychological trauma, it affects her mental health in the form of post-traumatic stress disorders, anxiety, depression, eating disorders, and suicide tendency. This also makes her more prone for substance abuse in the form of alcohol, tobacco, cigarette smoking, and other drug abuse. If her mental health is affected, then it makes her more prone for certain non-communicable diseases in the form of cardiovascular diseases, and she is more prone to get hypertension in the long term. She also is more prone to get somatic disorders in the form of irritable bowel syndrome, chronic pain syndromes, chronic pelvic pain. The third aspect of intimate partner violence is fear and control. That is limited sexual and reproductive control, lack of contraception, and unsafe sex because of the fear of the partner. The healthcare seeking, there is a lack of autonomy and difficulties in seeking care and other services. Perinatal and maternal health is also affected if this pregnant woman is subjected to intimate partner violence, and this can result into low birth weight, prematurity, and miscarriages. This intimate partner violence also has effect on sexual and reproductive health in the form of unwanted pregnancies, abortions, HIV, other sexually transmitted infections, and gynecological problems. 42% of women who have experienced physical or sexual violence at the hands of a partner have experienced injuries as a result. It definitely affects her mental health. She is twice as likely to experience depression. She is almost twice as likely to have alcohol use disorders, 16% more chances to have a low birth weight baby. She is twice as likely to have an abortion. There are increased 1.5 times increased chances to acquire HIV and 1.5 times more likely to contract syphilis infection, chlamydia, or gonorrhea. 30% of all murders of women globally were reported as being committed by their intimate partners, and 4.5 times she is more prone to commit suicide. So now friends, it's time for you all to respond in the chat box. So it's a quiz time. You have to state myths or facts. Statement I am giving: intimate partner violence is more prevalent among poor women and girls. This is a myth or a fact. I hope you all have replied in the chat box. Answer is it is myth. Studies have shown that gender-based violence can happen among people of all socioeconomic, all educational and racial backgrounds. Violence may affect our peers, colleagues, and friends. So it can happen to any class of women irrespective of caste, creed, age, socioeconomic status. Now the second statement, in some instances, especially when it is not severe, beating by a husband can be an effective form of discipline if the wife is acting inappropriately. Friends, this is a myth or fact. Don't get shocked by this statement because in India it is still, and many states, many men, they believe in this fact. Answer is definitely it's a myth because gender-based violence is a serious human rights, health, and developmental issue impacting survivors, their families, and the health and development of entire communities. So the third statement which I am putting across is majority of sexual violence against women and girls is perpetrated by strangers. This is a fact or a myth? The answer is it is a myth. Studies consistently show that most women who experience sexual violence are abused by people whom they know. Often the perpetrators are those they trust and they love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. This is another statement. It is safer for a woman to leave a relationship with an abuser than to stay. So friends, waiting for your response in the chat box. It is a myth or a fact? The answer is it is myth.
Nobody is
Violence.
answering, Lakshmi, I think.
I should wait while? Okay.
I don't know. I think all of them are just enjoying Sunday, and we request everybody to answer, please.
Ma'am, I've answered all the questions.
Yeah.
I mean, it is. I'm answering.
I have answered all the questions.
This is an interactive session. We all want your inputs. So friends, the answer
No.
to this statement is it is a myth.
Ma'am, I've answered all 4 questions.
Great. Violence often continues and may even increase after a woman leaves her partner. In fact, a woman is at risk of being murdered is greatest immediately after separation. So this point should be remembered. So friends, gender-based violence is a serious human rights, health and development issue impacting survivors, their families, and the health and development of entire communities. So this is all about the overview of violence against women. I'm sure you all have registered and taken pre-test. Don't forget to take post-test and submit your feedback form to earn your certificate, which will come automatically on your email inbox. So thank you so much, friends, for your patient hearing. Back to Dr. Jamuna for further proceedings. Dr. Jamuna, please unmute.
Yeah, thank you so much, Lakshmi. I think it was an overview, which is, the magnitude of the effect and how these consequences not only affect the woman, but the family and in turn the community. So thank you so much. And now Dr. Rakhi Singh. Dr. Rakhi, you are ready with the second module, please.
I can see Rakhi, yeah.
Yes.
Rakhi, please unmute.
Unmute. Thank you, Rakhi. We are not able to hear you. Rakhi, we can't hear you.
Rakhi, you are not audible.
No, we can't. It's not audible. We can see the screen, but your voice, it's not audible. No, I can't. Still not audible. No.
No, Rakhi, we can't hear you. You can log out and log in again, or you have to just increase the volume at your end.
Probably there is a problem in the system.
Sound setting here.
I know it happens so many times for all of us.
Rainy season, na network issues.
I know.
Sometimes just because of network issues, there is problem.
Exactly, exactly. We request Rakhi to take another module. You are okay, Lakshmi, to take the second module?
If you say I am ready, I can take. Whatever you say.
We are not unmute Rakhi first. We are not able to hear you, Rakhi. Still not audible. Can you type? Can you chat in the chat box, please? Bashir, she's not able to connect. Bashir?
I hope I'm audible now.
Yes, very much, very much.
I have logged in through another computer.
Great, great, great.
With a big bang.
Yes.
Okay, now over to Rakhi Singh.
Just bear with me for just few seconds.
Yeah.
I'm just loading the presentation also in this, and I'll just open it up.
Great, great.
Sure, sure. I think all the modules are very interesting, and they actually guide us how to deal with these women and how we can support them and help them. I think all the members today who are attending will find it very useful in our day-to-day practice, because definitely all of us will come across these women, and I'm sure Lakshmi will agree with me.
Yes, yes, Dr. Jamuna, very rightly said. And today's module is a very, very informative module, as Dr. Rakhi will be speaking on approach. How should these women be approached who face violence against women? Then we have effects of vow on pregnancy and newborn, then mental support, the challenging issues, the support system for survivors, how to approach a sexual violence victim, and most importantly for all of us as OBGYN is examination of a survivor and collection of evidence. As no one can say I am not equipped to do this examination. So this is the last part. So I request everyone to stay tuned and stay till last to get all the information about this module of violence against women. Yes, Rakhi, are you ready? Yeah.
We can
Yes,
see your
ma'am.
screen.
Yes.
Sorry for all the hitches and glitches because of the net. I had to change the computer also, and the whole presentation had to be loaded. It again went on a different tangent. Okay. Hopefully, I am able to do it. We're
Perfect.
going to talk on how to approach a woman who is facing violence, basically. Is everybody able to hear me now?
Yes,
Hello?
ma'am.
Yes,
Yeah.
yes.
Basically, why do survivors not seek help? We need to understand that. It could be because of the victims' blaming attitude of the providers, that we are not supposed to blame and we are not supposed to tell it is just because of you what the problems are happening, or it could be the fear of shame or the stigma what the person is facing, or there could be a fear of no confidentiality, inappropriate services, or services that are not useful or prioritized by the survivor, or it could be the perceived impunity of perpetrators, or it could be any other reason which you can put up in the chat box. We would be waiting for your inputs, dear, all of you. Basically, who can play the role of the help of the survivor? It could be the individual per se who is facing all the tune of the music, or it could be the family and the friends, or the service healthcare provider herself could be helping out, or it could be the community which can come forward and help the person out to overcome all these problems. There is a big role of the family, friends, and the community which plays for the help out of these survivors. The recovery from the violence dependent on the extent of the support received from the loved ones. Health professionals engage with the family and discuss ways of promoting survivors' well-being. It should be discussed with all the caregivers that survivors should not be held responsible for the assault. A child sexual abuse, parents may experience anger, confusion, guilt, self-blame at times. We need to assure them, reiterate that it is the perpetrators who misuse their position. It is not you who are at fault, or not you who is guilty for all these unfortunate events what happened. There is a big role of the healthcare provider. All the women are likely to seek health services at point in their life. Healthcare providers are often trusted by women and serve as role models in the community. Violence is an underlying cause of injury and ill health, which we all know under the closed doors, behind the closed doors when we talk to all our females, when we are examining them. Role of the healthcare providers in creating an good atmosphere and enabling trust is important. Whenever we are speaking to the survivor, try to speak with them in the private space, alone. Recognize their courage and reaching you as they have overcome several barriers before they can open up. Recognize the dilemma faced by the survivor in reporting violence. Do not report, do not label as non-reporting to police as a false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of available resources, legal rights, so that they can take an informed decision accordingly. There is a big role of healthcare providers. The healthcare professionals should prepare the survivor for an internal examination, explain in depth at the various stages of the examination, communicate to them about the rationale for referral for the X-ray, ultrasound, age estimation, and among all the other list of investigation what are required for them. And recognize the survivor may be present with the varied emotions at that point of time. Encourage the survivor to express her feelings. Encourage the survivor to seek crisis counseling. Access the suicidal ideations if the patient is having. That's an alarming sign which we need to understand. Make a safety assessment and a safety plan. Involve family, friends in the healing process of the survivor, which is required. Ideally, what we can say to the survivor when we are talking to them, either we can tell, take your own time, share only what you would wish to share or would you like to share. I can imagine that must have been a really hard for you. It takes a tremendous amount of strength to share what has happened to you. How do you think we can help you out? You are not alone. We are there along with you to help you out. There's mnemonic to remember the practical approaches, that is solar. S for the sitting position, how we are sitting, that matters a lot. With an open posture, we need to sit down, leaning forward with an eye contact to the patient, and give a relaxed approach and undivided attention to the patient so that the patient can open up easily. The supporting GBV survivor using the LIFES approach. Again, the LIFES approach is listen, inquire, validate, enhance safety support to these patients. Among the listening, listen to the survivor with your own eyes, give her undivided attention, ears, truly hearing her concerns, and give her full concentration, heart with a caring and respect. Ask all the open-ended questions to her. Be focused and close to the patient. Use good body language, posture, and eye contact. Avoid mostly the leading questions and the compounding questions to the patient. There are a list of do's and don'ts what we need to do while we are listening to the survivor. That is how we need to act. Be patient and calm. Let the client tell her story at their own pace. Do not pressure her to tell her story fast. Don't be impatient. Let her know you are listening through the verbal, non-verbal clues. For example, nod your head or say, Maintain a gentle and appropriate eye contact with them. Do not look at your watch or speak too rapidly. Don't answer the telephones or look at the computer or write anything. Give undivided attention to her. Attitude makes a difference. Acknowledge how she is feeling. Don't judge what she has or has not done or she is feeling. Don't say you shouldn't feel that way or you should feel lucky you survived. We are not supposed to tell that. What we are supposed to say is give her the opportunity to say what she wants. Ask her, how can we help you out? Don't assume that you know what is the best for her. Don't interrupt or wait until she has finished before asking. Encourage her to keep talking. If she wishes to ask, would you like to tell me anything more, or if there's anything else which you want to inform us? Allow for the silence. Give her time to think. Don't try to finish her thoughts for her. Stay focused in her experience and not offering any support. Don't tell her about something else, someone else's story, or talk to her about your own troubles. Acknowledge what she wants and respect her wishes. Don't think and act as if you must solve the problem yourself for her. In this inquire, how we need to act is phrase your questions as an invitation to speak. Ask open-ended questions instead of yes or no questions. Check your understanding by restating what he or she says. Reflect back to the client the feeling they express. Explore is needed. Ask for the clarification if you don't understand. Help her to identify and express her concerns and sum up the conversation to her. And what we need to answer to them is, would you like to talk about it? What? How do you feel about that? You mentioned that you feel very frustrated. It sounds as if you are feeling angry about that. Could you tell me more about that? Can you explain that again, please? It's there. Anything that you need or you are concerned about, you seems to be saying that. We need to validate, show that you understand and believe them. It's not your fault. You are not to be blamed. You did the most important thing you could do in that moment. You survived. Help is available. No one deserves to be hit by their partner. You are not alone. Unfortunately, many others face this problem. What happened has no justification or excuse. Your life or your health are your values. Everybody deserves to feel safe at home. I am worried that this may be affecting your health. These are some of the understanding and the beliefs what we can tell and communicate. Validate does not mean to try to verify the survivor story, for example, through interviewing the alleged perpetrator or witness. This is not safe, appropriate, ethical, or recommended to any of the survivors. Coming down to sympathy. Sympathy is a personal emotional identification with the survivor's experience and implies that the survivor provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over involvement in involvement and can take power away from the survivor. It is identifying with the survivor's experience, though your own choose. Empathy implies to intellectual or the personal understanding and realistic professional distances. It involves the compassion and objectivity and leaves room for empowerment of the survivor. It is the attempt to put oneself in the survivor's shoes. Ignoring violence can do more harm. What is the possible behaviors and what are the possible consequences? Let's understand that. Blames or disrespect of the woman or the girls can inflict additional emotional distress or the trauma. If we don't recognize the gender-based violence behind the chronic recurring conditions, then the woman receives inappropriate or inadequate medical care, fails to provide post-rape care or additional GBV or the family planning or STI or HIV care, can lead to unwanted pregnancies, STIs, HIV, unsafe abortions, and more violence to the patient. Breach of the privacy or confidentiality needs to be maintained. The partners or the family members become violent after overhearing the information. Ignore the signs of fear or emotional distress. Woman is later injured, killed, or commits suicide. So we need to be giving importance to her emotional fear and the distress. The doctor helped me feel better by saying that I don't deserve this treatment. And he helped me to make a plan to leave the house next time my husband became violent. The patient do remember that way to all for themselves and do communicate to their friends also in that way. So we are the caregivers. We need to support them at length. The mental health support system, there are various helpline links which are available, either with the health support or the psychosocial support. The legal justice system is in place. The security for the person is there in place, which you are going to understand and learn at length in these sessions today. A warm referral practice helps a woman reach further with the care. Dear friends, a registration test we have all given. We need to give the post-registration test and a feedback so that we have a certificate which can be awarded to all of us, and attendance certificate, we can get it after this. Thank you all.
Thank you so much, Rakhi. It was wonderful. I think that way of talking and your body language and all that is very, very important when we are dealing with a woman who has come to us for help. I think we move on without wasting time. We move on to the third topic, which I am going to take. That is effect of effect of violence against women on pregnancy and newborn. So, and we are thankful to the contributors, Kiran, Mai, Vidya, and it is curated by Kiran and Ajay. So, as we all know, it is initiated by Dr. Shanta, who is the president of FOXI. So we have now understood about what Rakhi has said and what is the objective. Now we will see how we can, if we ever seen a patient in our outpatient who have been the victims of violence or abuse. So how do they present? And remember, have you any time diagnosed them? And what are the common clinical presentations? Just recollect a case seen if you have come across one. So before that, now the WHO in 2005 have said that the maternal death, 90% of maternal deaths are avoidable. And we know this, it may be because of severe bleeding, infection, eclampsia, obstetrical labor, unsafe abortion, and other direct or indirect causes. But as we all know, postpartum period is 60% and 50% in 24 hours, 6 causes and 3 delays, and all these we all know about it. So what is behind these causes? I think you will be surprised and you'll feel very emotional and sad at the same time when you know these causes. The high level of the violence is during pregnancy. This is one of the women who has told when she was interviewed in Peru. He hit me in the belly and made me miscarry 2 babies. And I went to the hospital with heavy bleeding and they cleaned me out. So this happens not only just in our country, but all over the world. Now I'll be just sharing few of the case studies. This is case 1 where a primee has come with PROM and prolonged obstructed labor presented with ruptured uterus, shock, maternal mortality. So we all think in terms of pregnancy, but you'll be surprised to know that there was, when it was coaxed, then there was a history that brutal kicking on the abdomen by the husband, and he pushed violently, falling on the sharp edge, and death was due to the violence. Now this is the situation. And the case 2, there is previous 2 sections. She came at 28 weeks. There was antepartum hemorrhage. She was in shock and placenta accreta. So hysterectomy was done, 10 units of blood transfusions, and there was bladder involvement and all. So, but this was a maternal, complication because of pregnancy or the labor? No. What precipitated bleeding? The husband kicking on the abdomen. Now we come to the case 3, where a woman with severe preeclampsia and unconscious. Eclampsia with, it was thought that it was a vascular accident. It was leading to maternal mortality. And it was diagnosed as death due to eclampsia. But do you think it was right? It was correct? No. Actually, it was the violence by husband, and postmortem has revealed that there was a fracture in the skull, and because of that, cerebral hemorrhage and direct death due to violence. This is the magnitude of the violence which is seen during pregnancy, and hidden violence masquerading as maternal disorders. So case study 4, this is a Gravida 3 para 12-2 and with previous 2 LSCS, and it was full term. And she had a rod implanted for fractured femur and hip joint, and she collapsed in front of a hotel, and she was brought to hospital in 108 ambulance, and she was in active labor with severe hypertension. Emergency LSCS was done, and the consent was given by the RMO because there was nobody. And you'll be surprised. And she was pushed from second floor 3 years back. And now she was abandoned in labor. So this is another case where she was gravida 3 para 2, no living, and died with 2 previous LSCS, and she was 36 weeks with severe anemia. And both times there was a physical violence. The husband was kicking on the abdomen brutally, and followed by the loss of fetal movements. And third pregnancy, somehow the parents have taken her, and because of anemia, blood was transfused, LSCS was done, and she was given a live baby. So this is another case. This is gravida 6, para 2, L2, and all 3 abortions, and previous 2 cesarean sections, and 3 were induced abortions. And she came with acute hemorrhage, shock, sepsis, incomplete abortions. And this is another case of severe form of physical, emotional violence, where they forced her to go for abortion and later abandonment. And domestic violence history was brought out only when there was screening. She received 4 transfusions and failure. And these are the pictures where we can see that the physical violence, how it was. And this is you all can know that there was a perforation because she was hit by a rod. So stab injury has been in inebriated condition, lacerations on the face, perforation of the uterus, and she had IUFD, and laparoscopy is done, rent was required. And mind you, these are the cases which are brought down. I think I should tell that Kiran has done a study in the government hospital where she was working earlier. That is a maternity hospital in Hyderabad. And she has made a presentation of these cases. And they were really real cases. And it was very heartening to see those cases. So as obstetrician and gynecologist and as specialist, we have a stakeholder and in women's health. I think you all agree with me. So to assess and provide support for these women who experience violence because of the nature of the patient, because our relationship with the patient, they are emotionally bound to us, and we can assess and provide support to them. So there are many opportunities I think we get for intervention in our course of professional practice, that during adolescence we may get an opportunity, during pregnancy or family planning when they come for annual examinations, or for any other health visits if they come. We can take this opportunity when we at least feel that they are going through some abuse, and we can support them. So we can how to elicit questions. So already Rakhi has said that it should be not direct, it should be indirect questions. So that may help them. So the following may be helpful. Is everything all right at home, or anything is worrying you? Are you getting on with your partner, or something is worrying you? So such questions would be better. Now we have a lot of screening tools. I think you can go through these screening tools to learn how to assess, and abuse assessment screen, and this HAC, that is humiliation, afraid, rape, kick screen, hurt insult, threatened screen hits. There is ongoing abuse screen, ongoing violence assessment tools, partner violence screen, slap, thrown, and threatened screen, women abuse screen tools, vast. Then women's experience with battering scale. So there are so many wonderful tools for us to learn, and we can take these tools to assess. Then WHO has recommended that we all health professional can be trained, because we are the first line response to the family violence. So what are those steps? So as already told, that listening is very important, and we need to believe it. We should not be judgmental, and inquire about their needs and validate the person's experience. Don't jump into conclusions. enhance safety, and offer ongoing support. Then what is this universal screening or routine inquiry? That is asking all women at all healthcare encounters. But about intimate partner violence, that's not recommended earlier. But however, WHO guidelines identify that during antenatal visits, where routine inquiry can be done if providers are well trained on the first line response and minimum requirements are met. So that's an opportunity for us to identify these violences. So before you help her, ensure your safety also at the same time, and the person's safety also. The evidence on benefits and potential harms of the clinical inquiry, we should always be alert, and whether the subsequent interventions is lacking or you are uncertain about it. This is very important. A minimum condition for healthcare providers is to ask women about violence is that it must be safe to do so. That is, the partner is not present. This is very important. And when a partner is not present, you have to ask the question. And that identification of intimate partner violence is followed by an inappropriate response. So detailed guidance on responding to IPV and sexual violence against women can be found in this 2013 WHO clinical and policy guidelines, which can be downloaded and you can go through that. So as after every module, we all request that you have to do your post-test and feedback so that the certificate can be avoided, and feedback is very important for us. Thank you so much. And I think now, as Anasuya Sengupta has very well said, that many women in many parts of the world speak the same language, that is language of silence. I think we have to break this silence. And it is obstetrician and gynecology. Yeah, please mute yourself. So as obstetrician and gynecologists, we should be the voice of this be silent victim. And I hope we will all do that. Thank you so much. Now.
Thank you, ma'am.
Yeah. Now I think we will move on to, I'll stop sharing the screen. Yes. Now we move on to the fourth module. I think I invite Prema Priya. Is Prema Priya there?
Yes, ma'am. Good evening, ma'am.
Good evening. So please go ahead with your module. Thank you for joining and giving your valuable time.
Thank you, ma'am. Good evening, all. So today I'm going to talk about mental health issues, the woman who suffered violence. Is my screen visible, ma'am?
Not yet, Prema.
Ma'am, I couldn't share the slides. Can somebody share the slides, ma'am?
Okay, I'll just try.
Because the sharing option is not working, I guess.
Okay. Never mind.
कार का एक्सीडेंट हुआ, ये आदमी मर गया, बहुत बड़ा आदमी था, ऐसा कार हो गया.
Yeah, can you see? Prema?
Ma'am, 1 second, ma'am.
I have shared.
It's not yet open, ma'am.
No, I have shared for you. Can you see?
बहुत बड़ा आदमी था.
No, ma'am.
You can't see?
तो साइरस मिस्त्री मर गया है. Tata the chairman.
Dr. Amrita Saluja ma'am, can you mute yourself?
One second.
Dr. Amrita ma'am, mute yourself, please.
I've shared.
कार कैसे हो गए थे बच्चे?
Bashir, can you mute?
Can all of you see the screen? Kiran, can you see the screen?
I can see, ma'am. I can see.
Yes, ma'am.
Prema, can you see?
I can see. I can see.
No, Prema is not able to share, so I shared for her.
Dr. Amrita.
Prema Priya. I have shared, Prema.
Ma'am, yes, ma'am, I could see, ma'am.
Yeah, now you can talk. I'll keep changing. No.
Okay, ma'am. I'll just have to zoom it.
Okay.
Ma'am, you have to change, I think.
Yeah, but she has to talk about this.
Yes, yes.
Because next topic also she has to take. I think all these connecting issues, I think, Kiran. Share. I can stop share.
Ma'am, am I audible, ma'am?
Yeah, audible.
Ma'am, I logged in through mobile, ma'am. I'll share the slides, ma'am.
Yeah, please do that.
Yes, ma'am.
Yes.
Is it visible now, ma'am?
Yes, very nicely.
Okay, ma'am. Thank you, ma'am.
Right.
So the next topic is mental health issues, the woman who suffered violence. I thank Dr. Ramani Devi ma'am, Deepa Magudan, Kiranmai ma'am, and Dr. Ajay sir for curating this PPT. So coming to case report, Mrs. R, 26-year-old woman, was brought to the hospital with complaints of sudden abdominal pain. She was 28 weeks pregnant and married for 1 year. And this was her first pregnancy. She was a booked patient on regular ANC checkup, not a down diabetic or hypertensive. On examination, patient was very much depressed. Her vitals were stable, uterus was 28 weeks, irritable, and fetal rate was normal. Vaginal examination was unremarkable. On inquiry, she came up with a history of being beaten by her husband. So, what are the details to be gathered from the patient? Please put your comments in the chat box. Whether we need to inform the police, how to counsel the patient, what are the problems the patient can come across, what about family counseling, any drugs do you want to suggest, and what about the aftermath of intimate partner violence? We'll do one by one in the upcoming PPTs. Please put your comments in the chat box. So there's a need for the triad of consultations. We, the obstetricians, are the primary care providers. And we should also include psychiatrists and psychologists in the intimate partner violence, in the woman suffering from WAV. Why the mental health support is needed? Post-traumatic stress disorder is perceived as a lifetime threat or injury. It needs hypervigilance because of the mood disorders, substance abuse, sexual disorder, phobias, functional GI symptoms, dissociative symptoms, and even social withdrawals. So the role of obstetrician includes 3, intervention, that is risk assessment, which includes assessing the risk, whether it is increase in frequency or not, about the severity, whether the violence is chronic in nature. And safety assessment risk. Safety measures from the further assault from the partner, psychological screening, suicide and danger assessment, assess for the domestic and homicide risk also. These are considered the danger signs. If the frequency of violence is more, presence of severity of injuries, alcohol misuse, if the partner threatens to kill, sexual violence, suicide ideation in the woman, partner has access to weapons, morbid jealousy in the partner. These are considered as the danger signs. So whenever the woman had severe medical injuries, suicidality or homicidal thoughts, dissociative or psychotic symptoms, mood instability, self-destructive behaviors, and serious threat to the patient's life, then we need to hospitalize. Coming to the individualized multidisciplinary treatment plan, the primary treatment modalities include, as I mentioned, safety assessment risk, suicide and danger assessment, milieu therapy, which is nothing but changing the lifestyle or the environment of the victim, giving the psychological counseling, mood stabilization, medication evaluation, psychosocial support, need for rape kit, photo documentation, and reporting the legal concerns. Coming to the trauma recovery clinic, this is one started in 2014 in Nimans. The objective is that it enables the survivors with trauma to reclaim their lives by reducing the emotional symptoms of trauma, by enhancing their self-esteem and resilience, improving their social support, and prevent re-traumatization, conducting awareness and capacity building programs involving the psychologists and counselors. Coming to the psychosocial impact in the victim, they feel helpless. There's a progressive erosion of their confidence and self-esteem because of the abuse. They feel guilt, shame, isolation, traumatic bonding. This is paradoxically strengthening the emotional ties to the perpetrators. Physical separation due to increased risk of homicide and decreasing the coping abilities in the victims. So the psychologist plays a main role in the treatment, especially in case of post-assault, psychotherapy, cognitive behavior therapy. This is variant of cognitive behavior therapy. It helps the victims to emotionally process the assault by decreasing the fear to memories or cues of the event. So focused cognitive behavior therapy is given. Coming to the STAR, that is skills training in affective and interpersonal regulation. So psychoeducation about the impact of trauma on emotions and relationships, emotional regulation skills, effective expression of negative emotions, interpersonal skills, development of flexibility in regard to interpersonal expectations, actions, and reactions. Treatment also includes recognition of achievements during the treatment and exercises in self-compassion. Interpersonal psychotherapy. It has been shown to be an effective non-exposure-based treatment for post-traumatic stress disorder. Many of them reflect interpersonal difficulties such as emotional withdrawal from the relationship and individuals, interpersonal deflects, sometimes results in interpersonal hypervigilance. Other newer psychotherapies include cognitive process therapy, eye movement desensitization reprocessing, HOPE, that is nothing but helping to overcome the post-traumatic stress disorder through empowerment, relapse prevention, and relationship safety. Women experiencing intimate partner violence-related depressive disorder or alcohol disorder should receive mental health care as per WHO Mental Health Care Action Program, led by healthcare professionals with good understanding of VAW. CBT and EMDR interventions delivered by healthcare professions with good understanding of VAW are recommended for women who are no PTSD. According to WHO recommendations for depression and other emotionally or medically unexplained complaints, for mild and initial phase, there is no role of or benzodiazepines. In case of moderate or severe depression, then tricyclic antidepressants or fluoxetine is given. Episode, then no need of drugs in the initial phase. The duration of treatment is continued for 9 to 12 months, even after recovery. Interpersonal therapy and cognitive behavior therapy includes behavioral activation and problem-solving treatment. Also, relaxation training and physical activity are given. In case of recent trauma event, psychological debriefing and psychological first aid in case of acute distress are recommended. Men group treatment therapy. We should encourage men to take personal responsibilities for violent behavior, challenge attitudes or beliefs around the use of violence in a relationship, develop skills for reacting non-violently to others, and increase the awareness of dynamics involved in the use of violence. So mental health is an issue in violence against women, affected women, and thus it needs to be addressed along with the physical health. Kindly fill your post-test and feedback form for receiving their certificate. I'll just load the next PPT. Shall I proceed, ma'am?
Yes, Prema. Yeah, please.
Coming to the challenging situations involved and self-care. When dealing with a survivor who may be feeling hopelessness, having suicidal thoughts, or in harm's anyway, what would you do? You are a gynecologist and one of your patients in your clinic tells she's being threatened by her mother-in-law who is constantly pressurizing that she must divorce her husband because she's unable to have children. She feels hopeless and wants to give up. You do nothing or you do something. Please put your answers in the chat box. Here are a few ideas. Be able to recognize signs of depression and suicide risk. Do not be afraid to ask, are you having thoughts of suicide? If the answer is yes, then take it seriously. Do not leave the suicidal survivor alone if there is immediate danger. Always consult your supervisor about how to refer or manage your suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. Provide a referral to Gender-Based Violence Expert Agency or One-Stop Crisis Center for additional help if possible. Here is a quiz. Obgyns should not ask survivors about suicidal thoughts or attempts because it encourages them to have suicidal attempts. Is it true or false? Please put your answers in the chat box. The answer is false. Asking about suicidal attempts or thoughts does not increase suicidal attempts. On the contrary, talking about suicide often reduces the woman's anxiety about suicidal thoughts and helps her to feel understood. If the survivor tells you that the abuser has threatened to harm them, what should you do? Here are a few ideas, which includes ask concrete questions about the safety risk, but only when there is privacy. Ask if the survivor has a safety plan in case she needs to flee. Discuss the potential strategies for being able to leave her situation safely. Provide a referral to Gender-Based Expert Agency or One-Stop Crisis Center for additional help if possible. One of the most helpful techniques for helping a survivor to get out of an overly emotional state is to ask them close-ended questions that require them to think. Shift them from an emotional state to a cognitive thinking state. Should require short answers. Do not return to open-ended questions unless the survivor feels comfortable and has some degree of emotional control. Here are some examples of close-ended questions, which includes how many kids do you have? She may answer 1 or 2. Are they in school right now? What are their ages? Then she'll slowly open up. Coming to the challenging situations when dealing with a survivor who may be mentally ill. State clearly who you are and what is your role. Be empathetic. Be non-threatening and sincere in your intention to help. Give honest, factual answers whenever necessary. If you do not know, then say so. Do not belittle concerns which the survivor raises. Do not give advice as to the handling of their psychological problems. Attempt to be supportive in comments and also in gestures. Do not assume mentally ill people should know better, or on the other hand, that they need to be told what to do so. Be careful about making any assumptions. Know how to activate the emergency mental health backup. Additional challenges include mediation. What do you think? Can we be a part of mediation process? Mediation is not recommended as a response to gender-based violence. Health workers are part of survivor-centered referral mechanism. The mediation process itself maintains and contributes to the abuser's ongoing power and control over the survivor. The process of mediation presumes that both the parties can speak freely, confidently, and safely, but that is not the case. Mediation very rarely results in an end to abuser's violence. It actually leads to an increase in the violence. It is unlikely that the survivor's rights will be respected. Coming to core safety precautions when dealing with the challenging issues. Multiple people can handle difficulty better and more effectively than a single person. A service provider should never feel like she or he must work alone with the survivor. A service provider should not work with both the perpetrator and the survivor, neither separately nor in the same interview. Keep the office door open if feeling unsafe. Establish a code, example code word, with co-workers to identify the unsafe situations. Establish a relationship with local police or the security. Use buddy system at work and to and fro from work and if doing home visits. Use supervision to address security concerns. A group of people can address security more effectively than a single person or an individual. Do you know what is vicarious trauma? It is mainly for the healthcare providers. Please put your comments in the chat box. As a service provider, you should be aware of it for your self-care. Vicarious trauma is a change in service providers' inner experience as a result of emotional engagement with the survivors of trauma and hearing their stories. Changes that occur in the service provider's physical, emotional, and behavioral states as a result of constant exposure to the traumatic stories or events. So the causes are constant exposure to traumatic stories or events and desire to help or change the survivor situation, feeling powerless when a service provider does not see positive changes in the survivor situations, overly identifying with survivors, thinking the service provider has a power to change a survivor's situation. These are the causes of vicarious trauma. How to prevent and manage it? It is mainly by the mnemonic ABC. That is awareness, being attuned to one's needs, limits, emotions, and resources, and practice self-acceptance. Always maintain a balance among the activities, especially work, play, and rest. Maintain supportive relationships. Communication is a part of connection and breaks the silence of unacknowledged pain. These connections help prevent isolation and increase the validation and hope. So, how to do self-care? Create boundaries in the workplace. Establish support within the work environment. Seek assistance from outside agencies. Create your own self-care plans and follow them through. And this is the quiz, which contains 2 statements. Already Raki ma'am has said about that. Can somebody put in the chat box which statement deals about the sympathy and which statement deals about the empathy? So the first is a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. This is the statement of sympathy. And the next is empathy, that is an intellectual or personal understanding and realistic or professional distance. It involves compassion, objectivity, and leaves room for empowerment of the survivor. All we need is empathy. So how do you take care of yourself? Please put your comments in the chat box. What relaxation or self-care techniques you follow so that it will be useful for others also. So I like to remind that after the end of these sessions, there will be a post-its and feedback form. Kindly fill those to get your certificates. Thank you. Thank you for your patience listening.
Thank you so much, Priya. It was wonderful. I think we have learned how to be prevent our vicarious trauma. That is very, very important. Yeah. I think I must tell that Kiran was part of this whole module creation.
Thank you, Kiran ma'am.
Thank you. Thank you, Jamuna ma'am. Thank you, Jamuna.
Yes.
Thank you, Prema. You covered it well. Thank you so much. Yeah.
Yeah. You'll start, Kiran?
Yes, ma'am. Thank you, ma'am. Yeah.
Achha, Anita is also there. Very good.
Yeah. A very good evening to all. Jamuna madam, thank you for coordinating this session today. And without further delay, I'll start the next presentation. That is, today I think every one of us is facing some glitches.
I know.
I think too many windows open. I'm closing. Yeah. Just give me a second. Yeah. Is it visible?
Yes, it is visible, but it has to go to slideshow.
Slideshow. First of all, I would like to thank Shanta Madam for this vision and mission from just being the awareness and sensitization campaign which Madam started, and we were all fortunate to be part of in 2016 to developing these very useful, practical, and really which will bring about a change. I hope these modules both in schools as well as for the OB-GYNs. So with this, so after knowing how violence against women acts in the health perspective and how it affects the pregnancy and women's health and mental health issues and how it affects us as healthcare providers and vicarious trauma etc. We'll now move on to the now what to do. We know that problem exists, we know how it interplays and how it reflects in our patients because we deal with women. So now what to do, how to offer the resources and support systems without endangering the patient safety and our safety. So that is this purpose of this presentation. Dr. Anita Sabarwal madam and Dr. Jyoti Banglawala, Dr. Rohan and Dr. Ramani had contributed to this PowerPoint. So this module, support systems and resources. Yeah. So overview is we'll just deal with what are the protective laws and acts because we need to know what are the protective laws and acts. Most of us may not know. Then what are the helplines that are available across the states and India so that we can tell our patients or victims that these are the helplines available. And we all gynecologists have to know about this one-stop crisis centers. One-stop crisis centers that are there now, they are called as Sakhi centers. There used to be very few one-stop crisis centers maybe around 7 or 8 years back. Now the central government has made it. I have seen one in the small town that I am working, that is Vanaparthi Sakhi center, which is a one-stop crisis center. We'll see what are these one-stop crisis centers. Then finally, how can we link up and help in the rehabilitation of these survivors. So the Protection of Women from Domestic Violence Act has come about in 2005. So why Domestic Violence Act 2005? Were there not any laws before that? Actually 498A was integrated into introduced in the Indian Penal Code in 1983. But what were the pitfalls in 498A is that there was no emergency relief available to the victim after the complaint, and then remedies available were linked to the matrimonial proceedings, and the court proceedings were always protracted, during which period the victim was invariably at the mercy of the abuser. She would continue to live with the abuser mostly because of domestic violence, and she was no benefit was given to her because she would complain and she would still be at the mercy of the abuser. And relationships outside marriage, they were not recognized under this 498A. So that is the reason Domestic Violence Act 2005 has been brought into picture. It is a civil law. In 498, a husband is liable for punishment, but wife does not get financial relief. But in DV Act, the female partner gets relief, but there is no I mean, there is no punishment or arrest unless the husband violates the court order. Another difference in 498A can be booked against husband or his relatives, but DV can be booked only against male members of a family. These are the differences. Then who can be a complainant? It can be a wife, not always a wife. It can be any woman based on marriage, adoption, cohabitation, living together against a male abuser in a shared household. It can be brother, cousin, in-laws, anybody. Then a woman who is in a relationship which is similar to a marriage with a man, that is living together, and technically a transgender male to a female could bring an action against a transgender female to male. A woman in live-in relationship with an unmarried man, but not with a man who is married, if she knew or ought to have known that he was married, then anyone can file a petition with the survivor's consent. Then to whom she can complain. These are all the people to whom she can complain. There are protection officers under this act. There is a service providing center, then a medical officer in charge, and a police station or a magistrate. Then where can you complain? The jurisdiction under the Prevention of Women Domestic Violence Act is where she resides, the woman wife permanently or temporarily resides, or where she carries on business or employed, or where husband permanently or temporarily resides or carries on business or employed, or where cause of action has arisen, wherever that act of violence has occurred. So any of these three options the woman can choose. Then what are the immediate relief orders that she can get is, she can get an immediate protection order which will prevent further abuse. Then stop violence. Immediately the violence or abuse has to be stopped. That occurs immediately as soon as the complaint is registered. Then emergency relief is provided to her. And residence in shared household, irrespective of whether she has any right of ownership or lease. That means she cannot be abandoned or thrown out of house. So she retains that right of residence in that household, or she can require separate housing and the abuser has to provide separate housing if needed. She'll get a custody order, she'll get a compensation order, and violation of any of these above orders is an offense, and the magistrate may charge offense on the male perpetrator or abuser. In the section 21, this is non-compliance of this protection order by magistrate can lead to an issuance of non-bailable warrant. So this is all what we have to know about the Domestic Violence Act. Then what is the time limit? See, most of the times the justice delayed is the justice denied. So this act requires that all proceedings are brought under the act should be disposed of within 60 days. That is 2 months of the first hearing, which must occur within 3 days following the application. So hearing should occur within 3 days of the application, and within 60 days all the proceedings have to be disposed of. Then the services are offered are, you file a detailed investigation report. You can direct the complainant to a shelter home. You can facilitate, I mean, under the Domestic Violence Act, the government or the service provider has to facilitate free legal services and provide counseling services as required. You can see it is a comprehensive act, which is not just booking a case against the violator or the abuser, but providing the required relief to the victim. Then what are the other domestic legal remedies in India? We know that our constitution, it is a wonderful thing that which we are reinventing, especially after the America's Roe versus Wade anti-abortion, which are against the women's rights. The Article 14 in Constitution provides equal rights to women. And then we have a National Commission for Women, which was set up in 1992 under the National Commission for Women Act 1990. We also have a Dowry Prohibition Act, DPA, then 498A IPC, which is most widely used, and then we have this 2005 Domestic Violence Act. Then coming to the one-stop crisis centers, this example picture you are seeing is one of the first OSCC at Madhya Pradesh, which was named as Gauravi. It was a joint initiative of Department of Public Health, Family Welfare, Government of Madhya Pradesh, and the most important thing about this is they provide immediate medical, legal, psychological, and even financial needs of the women who are survivors. They are assured, they are addressed, and with an assurance that their consent and confidentiality will be respected and protected. Now, as I have told, there are 234 OSCC, which how they call it is, the terminology is OSCC, the short form, One Stop Crisis Center, or OCC, One Stop Crisis Center, all over India, which are popularly known as Saki centers. Then we have our Bharosa center at Hyderabad. She teams we all are in Hyderabad and Telangana are aware of. This is a state of the art center which we visited. I think Shanta madam met Miss Swati Lakra IPS, who is in charge of the she teams. Again, this is all in one center for violence against women. They have police, they have counselors, they have psychologists, they have legal advisors, and also medical help. And the helpline number here is 100, and it will be directed to Bharosa if it is violence. Any woman can walk in with the assurance that her consent and confidentiality will be respected and protected. Once this Bharosa and she teams have come, the crime rate against women in Hyderabad and Telangana has come down drastically. So I will not read out what is there in the next 3 slides. You just take screenshots of the next 3 slides. I think Dr. Anita and Dr. Jyoti have carefully taken out all the numbers of the helplines across India. So I've just put in 3 slides. Will not repeat it. Please take screenshots so that whichever state you are in, it might be resourceful to helpful for you to help out. So these are the central numbers. All India Women's Helpline 1091 is the number. As you know, Child Helpline is 1098. The Women in Distress is 1091. Another common central number in many states is 181. Even in our state, in Hyderabad and Telangana, any state it is 181. And then we have National Commission for Women's Numbers, Delhi Commission for Women's Numbers. Please take screenshot. Outer Delhi helpline, and then local bodies. These local bodies, NGOs and police stations and other states, I'm just put it here. The AP, we have Bhumika, Arunachal, I'll not repeat, Arunachal Pradesh, Andaman Nicobar, Bihar, Delhi, Jharkhand, Punjab, Chandigarh, Tamil Nadu. I hope you have taken the screenshot. And then these are the other states, so which we have put up in one place. So with this, I end this presentation with a reminder to do your post test and give feedback. And I also now request Dr. Anita, who has joined us. She will be taking about, we have 2 more sessions, talks. One is the approach to the sexual violence survivor. And then finally, I'll be taking the examination part, which is very important but extensive. I'll try to be brief and cover the important things in that without really boring you. But that is really important because many of us have a lot of doubts how to examine, what to examine, what to do, what not to do. Anita, Dr. Anita, welcome.
Yeah, thank you, Dr. Kiranmai. Good evening to everyone. Yeah. Shall I?
Yeah, I'll just stop share.
Okay. It was great hearing you.
Thank you.
Thank you so much. So
getting your facial and listening to this.
Okay. Yeah, can you see my slides?
Yes, ma'am. Yes.
Yeah. So again, now a very important topic, sexual violence and how to approach a woman facing this sexual violence. As we all know, sexual violence refers to any sexual act or attempt to do the sexual act or unwanted even sexual comments or acts to traffic which are directed against a person's sexuality using force, regardless of their relationship to the victim in any scenario, including at home or even while at work. So that includes, everything is included here under sexual violence. Rape is the term which is commonly used, but it is part of the sexual violence. So now we can see, as we just defined, rape is one of the parts of sexual violence. So as per WHO's definition, sexual violence includes, but is not limited to rape. So as we all know, rape is defined as physically forced or otherwise penetration of vulva or anus, either using penis or any other body part or even any object. So that is rape. But sexual violence includes rape, but other kinds of violence also come under sexual violence. So there are some really very interesting facts about sexual violence. Chances are that you know someone who has been sexually affected, and victims, they know who has assaulted them, and mostly victims, they are never at fault for a sexual assault. And rape, as we all know, is the least reported and convicted violent crime in our country. And we all know sexual violence is very much preventable. And as Dr. Kirnamai just mentioned, help is available. We just need to go and take the help and see in their state, already the crime has come down because of the help available. So these are the facts we all know and we must implement them. Then there are different forms and contexts of sexual violence. A wide range of sexually violent acts, they can take place in different circumstances and settings. Rape within marriage, so within marriage also rape can happen, or rape within dating when the friends, they know they have relationships, that is also called rape when it is done by force. Rape by, now this is by the known people, now rape by strangers, then systemically during any army conflict, and any unwanted sexual advances or sexual harassment, including demanding sex in return for favors, which many times happens in corporate places and otherwise also. Then sexual abuse of mentally or physically disabled people who are in a very precarious or kind of situation. And then ultimately we know so common sexual abuse of the children who don't even know the meaning of this act. And then post-marriage or cohabitation, including the marriage of children, which is still, I think, prevalent in many parts of our country. And not only in our country, in so many other places in the world. And then denial of the right to use contraceptive, which is really happening when we see in our day-to-day practice, because woman is not in charge of her body. And or to adopt other measures to protect against sexually transmitted diseases like condoms, they will refuse to use them. Then forced abortion, woman doesn't want to abort, but she's forced to abort. Then violent acts against the sexual integrity of women, including female genital mutilation and obligatory inspection of virginity. So forced prostitution and trafficking of people for the purpose of sexual exploitation. So these are all different forms and contexts of sexual violence. Now the customary forms of sexual violence or the child marriage. Marriage is often used to legitimize a range of forms of sexual violence against women. Marrying of young children, particularly girls, in many parts of the world, and legal in many countries, is a form of sexual violence. Children involved are unable to give or withhold their consent, and majority of these children don't know so much little, or they don't know anything about the sex before they are married, and they have to undergo this kind of violence. Now, what are the consequences of this sexual violence? Pregnancy related and other gynecological complications, as we all know. Then sexually transmitted diseases, mental health issues, suicidal behavior, and social ostracization. See, socially, then you will become the victim. And the fatal outcomes which are related to sexual violence are suicide, homicide, and AIDS related. And other ones, physical consequences of the sexual violence: unwanted pregnancy leading to ultimately infertility, sexual dysfunction. The woman has chronic pelvic pain. She has to suffer from these STIs, including HIV and AIDS. Then she may suffer from obesity or anorexia, urinary tract infections, GI tract infections, gynecological and pregnancy complications, then migraines, some frequent headaches, fatigue, nausea. They are part of this kind of consequences to the woman. And now the non-fatal, which are, but they really are troublesome, and other psychological consequences like rape trauma syndrome, such a traumatic situation, post-traumatic stress disorder. When these people suffer, you really know what it is. And social phobias, they're so scared of the society, they're not able to have any faith in anybody now. Shock, increased substance use or abuse. We are simply reading the lines, but these have such deep meaning, for these people when they're suffering from them. The denial, fear, confusion, anxiety, guilt, depression, alienation, and eating disorders. And how much they have to go through. It's really drastic for the woman once she goes through all this. So what should be the approach to the survivors of sexual assault? It is one of the most invasive and intimate form of violence. Trauma-informed care approach should be utilized, which involves thorough understanding of neurological, biological, and psychological and social effects of trauma and violence on the individual affected. So when a patient presents and reports a sex assault, triage the patient as a medical emergency. What are the immediate needs of survivor? Medical and or psychiatric evaluation and stabilization. Then activation of community advocacies to the bedside. Mandated reporting as directed by the state statutes. Offering and conducting, if desired by the survivor, the sexual assault exam. Collaboration with law enforcement if desired by the survivor, proper medications for STI and STD, pregnancy risk evaluation and care, and safe discharge planning. And those providing medical and forensic care must always be prepared for the testimony as either a fact and or expert witness in future, which may be required. Then application of trauma-informed care to the care of patient that discloses sexual assault is safety, trustworthiness, choice, collaboration, and empowerment ultimately. So safety, knock on the door and ask permission to enter patient's place. Meet with the parents before you disrobe the patient to examine. Ask the patient to disrobe only when necessary or only partially, showing complete respect to the patient, and provide and clearly identify the washrooms and tell them so that they feel comfortable. Take time to familiarize the person with the physical environment. Don't ask about the comfort level with lighting. Share control. Show respect is very important. Show empathy and use a warm and passionate manner to build rapport. It should be ultimately a very friendly, motherly approach. Then trustworthiness, explain all procedures in terms of person can understand, tell the person what to expect and how long it will take, and ask the person what he or she wants so that the person is very comfortable. And the choice, ask if you can take the permission, because if you have to touch and examine something, ask before you invite any additional staff, take the permission of the patient, ask if you can close the door with the permission of patient. The patient will feel very comfortable and will be able to examine very easily then. Allow the person to decide where to sit in the room, where she's comfortable. Explain everything to her about the procedure in advance so that she understands what is going to happen and she's not scared, and obtain consent for each part of the exam performed. And then collaboration, ask what are your top worries or concerns and address them as possible. Share information with her and encourage the person to make decisions about treatment. Empowerment, what is empowerment? You ask what happened to you, not what is wrong with you. So we should make them feel that, they know we are not making them feel low. Never ask why questions because they imply fault. And you take time with the person, so also he or she feels genuinely heard. Show your full concern. Don't look into your mobile or look elsewhere. Look into the patient's eyes and talk to the patient. Ask if the person has preferences related to or has any difficulty with the procedure. Ask the person what you should know before you begin the procedure. Ask if there's a way you can make the procedure easier for her or him, because the person affected can be him also. Ask if there's a way you can make the person relax, like a different position, and pay attention to body cues. Something you can make out from patient's expression is not comfortable or comfortable. And therefore the authority and so may not disclose distress during the procedure. So elements of the sexual history, medical history, recent consensual sexual activity, assault related medical history, sexual assault details, the nature of the physical assault, and then what activities were taken after the assault, and any information about the suspect. So all these part elements, they make complete history. So we have to take into consideration every part of this history one by one. So that will give us complete information about the patient. So this is how, if we go, we are empathetic, friendly with the person. So we will be able to gather a lot and we'll be able to help the person a lot. So thank you so much. And as Dr. Kenmay already mentioned, so we have a registration, pre-test, post-test, and feedback. So your certificates will be awarded on the attendance and submission of these registrations. So please don't forget to do that. And thank you so much. Thank you, Dr. Kenmay. I think now she will be taking the very important next lecture. Dr. Kenmay, please.
Yes, thank you, Dr. Anita. Ma'am, shall I start, Jamna ma'am?
Yeah, please. We are waiting for you.
Dr. Anita, you need to stop sharing it.
Yes, yes, I will stop sharing. And since I had come here to a Delhi Medical Association, so I will be joining them. So I was sitting in the car and doing. Okay, thank you so much. And I will stop shared. Yes. Right. Thank you. Thank you so much.
Thank you,
And bye.
Anita. You have taken your time
Thank
out.
you, ma'am.
Otherwise,
Thank you so
I
much.
was
Thank
supposed
you, ma'am.
to take her talk.
Thank you, ma'am. Thank you so much.
We go to the last presentation. This looks formidable and very difficult to start with, but I'll try to be very brief and cover only the salient features of examination of a survivor and collection of evidence, because this has both knowledge gaps are there for us, and also that we need to be medico-legally safe. And also will be doing a great help to the survivor if we really do the proper history examination and collect the evidence, so that it helps her in the court. So what is the role of us, that is the gynecologist? We use important evidence of the crime and help judges understand physical and mental condition of the survivor. We can use our reports to corroborate that survivor story and enhance credibility. And we offer primary level counseling, treatment, and referral for the physical and psychological sequelae. So our medical examination consists of these four parts. One is recording history, taking informed consent, documentation of injuries carefully, and then evidence of collection, which establishes the nature of sexual violence, time elapsed between incident and examination, whether survivor has bathed or washed, depending on so many other factors. So there are 25 components of this examination. This examination is not a random PPT which we have done. We have taken it from the Government of India guideline booklet. It is around 100 pages booklet. We have concised it to this short PPT, especially the examination part. So the 1 to 11 are slides are about general instructions, 12 is informed consent, then 13 is marks of identification, 14 history of medical and surgical, and 15 is sexual violence history, 16 is examination, general examination, 17 is for injuries, 18 is for external genitalia examination, 19 is systemic examination, 20 and 21 slides are for evidence and sample collection, 22 is provisional medical opinion, 23 is what treatment is prescribed to the survivor, and then date and time and completion, and then finally important thing is how to give a final opinion. So I'll not go through this each and everything. You all know these are the general information that we fill up, like name of the hospital, OPD number, etc., address, and then all the history, MLC number, brought by whom, and then name and signature of those people, and date and time of arrival in the hospital, and date and time of commencement of examination is very important, because maintaining time and the chain of evidence is matters a lot when we are giving evidence in the court, so that there is no how much delay is there when the victim arrives in the hospital. That is one important thing. I mean, how much time has elapsed when till she seeked care, and then how much time we have taken by the time we commence the examination. That also is very important to note. And then informed consent, very clearly this has to be, this format has to be there in your preliminary report when you send along with the police, when you submit. So this entire lines, I have understood the purpose, procedure explained to me, and my right to refuse the examination and the consequence, all this has to be explained to her in the language that she understands. And if needed, a special educator, interpreter, or support person has to be there. And then if they have help, then their name and signature has to be taken. And also we have to document the refusal. Sometimes the survivor may refuse for various reasons. That also has to be documented very clearly. Then marks of identification, I need not stress upon this, very, very important. And the left thumb impression of the survivor. Then coming to the relevant medical and surgical history, as you can understand, the menstrual history, age of onset, last menstrual period, which has a bearing on, kind of pregnancy and other abortion or other kind of clinical situations which can happen in sexual violence. Then if she was pregnant, duration of pregnancy, contraception use, and then history of sexual violence. Then important thing is when is it being reported, time of incident, where has it happened, then duration, episodes, number of assailants, name, sex, age, and if they are known to the survivor, and very clear description of the incident in the words of the narrator, and who is the narrator of the incident, and their relationship to the survivor, add pages if necessary. So we have come to 15b, that is type of physical violence. It's not just enough to say that there was physical violence. We have to very clearly, we can put a tick mark, hit with hand, fist, blunt object, or burned with, or whether kicking, pulling hair, banging. The type of physical violence is very, very clearly mentioned. You have to tick the relevant and answer or answers and describe if any necessity is there. Then emotional abuse or violence is also abuse. Then she may be threatened with the use of weapons or with the threat of that I'll kill you, or verbal threats, that is threats of killing or hurting the relatives, or blackmailing with the use of photographs or videos. If it is a child sexual abuse, luring with sweets, chocolates, or anything else, and any other thing, this also has to be very clearly mentioned if it is there. Then alcohol, drug intoxication also comes, and whether she was made unconscious at the time or sleeping, when she was sleeping at the time of incident. And then if the survivor has left any marks of injuries on the assailants, the details of this come under 15E. Then 15F is details regarding sexual violence. Then this table, this entire format is there in the Government of India module as well as in the Telangana government module also. You can Google it. I have put the resources in the last slide. Then we can share it with you if you need. So the organ involved, genitalia, whether vagina, urethra, anus, or mouth. Then by penetration by what? I mean, is it by penis or any other body part, by any object, whether emission of semen was there, yes, no, or don't know. Then whether oral sex was attempted, forced masturbation, and then exhibitionism. All sorts of violence have come into it. You can see that nothing is left without being mentioned. So that all we have to do is ask one after the other and document. And then where the ejaculation has occurred, whether condom was used, status of condom, any lubricant, any object was used. And then post incident details are very important, whether she has changed clothes, changed undergarments, cleaned or washed clothes, whether she has bathed, she has douched, passed urine, and whether passed stools, if it is oral sex, rinsing of mouth, etc. Then history of vaginal discharge, and history of painful urination, defecation, fissures, pain in genitals. All this tells us about chronic abuse, or the type of abuse which has been happening. All this has to be noted and documented. Coming to the physical examination, I'll not go into this. And examination for injuries on the body, you can ask these questions: what injuries, where are they, and how are they? So what are the types of injuries has to be very clearly mentioned. You can't say just an injury has a name. It can be a bruise, abrasion, teeth bites, cut. Is it a laceration? Is it a fracture? Is it just a tenderness, or a boil, or a burn? And where is it on the body part, and how it is, the size, shape, color, swelling, and any signs of healing. Is it simple or grievous, and what are the dimensions of it? Then coming to the external genitalia, you examine the labia majora, minora, urethral meatus and vestibule, fourchette, introitus, perineum, and hymen. And pervaginal perspeculum basically should not be done unless they are required for detection of injuries or for medical treatment. If you do PS and PV, you do the record the findings and also record reasons why you have done PS and PV. And then also don't forget to examine the anus and rectum for any bleeding, tears, and oral cavity also. Then systemic examination, CNS, CVS, respiratory system, and the entire abdomen has to be examined, because there can be bruises anywhere. There can be fractures anywhere. So collection of evidence, main important part of it. Why do we collect evidence or sample collection is, one is to obtain confirmation of the important allegation, to establish link between, by our collection of evidence, we establish this link between victim and the scene. You can see how important it is. And to establish the link between the victim and the assailant. We know that every contact leaves a trace. So it is important for us to maintain the chain of evidence, identify what specimen it is, very clearly label and sign the specimen, and uh, record the disposal of this specimen. Then sample collection, basically for lab and clinical laboratory, we collect blood for viral markers, HIV, HBs, AG, HCV. Then if necessary, we do urine tests for pregnancy, ultrasound for pregnancy or any internal injury, X-rays for injury. Then we send it to central or state forensic laboratory. Whatever debris we collect, that paper and the clothing evidence were available to be packed in a separate pack or bags after air drying. And the sample collection is, we take swabs from the stains, any stains if they are present on the body. The stains can be of blood, can be of serum, can be of foreign material. Then scalp hair if necessary for 10 to 15 strands, and head hair combing, nail scrapings, oral swab, blood for grouping, and if necessary test for drugs and alcohol if you suspect they are under the influence of that. Blood for DNA analysis, again depending on the situation. Urine for drug testing. If there is a tampon or sanitary napkin or condom object, even that has to be preserved. And if you're not collected, any reason for that not collecting has to be documented. So again, matted pubic hair, this is from the genitalia, and anal evidence, pubic hair combing. If it is shaved, you have to mention it. And two vulval swabs, two vaginal swabs for both semen and DNA, two anal swabs, again for semen and DNA, vaginal smear, air dried for semen examination, urethral swab. All these samples have to be preserved as directed and handed over to police along with the duly attested, signature. And if not collected, again reasons for not collecting have to be mentioned. Now comes the provisional medical opinion. I have examined so and so, age so and so, reporting so and so sexual violence, brief description, number of hours or days after the incident, after having bathed, douched, or and how many times. Now my findings are as follows. I have collected the following samples and that submitted for FSL awaiting reports. I've collected following samples for hospital laboratory, and there is a brief clinical findings and additional observations. So now we have to offer treatment for the survivor. So STI prevention, antibiotics if needed. If you think that she has the risk of becoming pregnant, emergency contraception, wound treatment, tetanus prophylaxis, hepatitis B vaccination if she has not yet taken, if even post-exposure prophylaxis for HIV also, if you think it is needed, or if the HIV status of the assailant is known, or even if there is any necessity, it is better to give a post-exposure prophylaxis for HIV also. You do the counseling and other services as required, and then you write the date and time of completion, that, and also that this report contains this number of sheets and this number of envelopes, and you do the signature, name, and the place seal. So this completes your preliminary examination, and you submit to the forensic and to the police for the further necessary action. Now final opinion. So now you receive the lab reports in the following mentioned formats. There are prescribed, I can say 11 total 11 final opinions which can be given. You should not deviate from one of these final opinions, whatever is the condition where such every finding fits into the one of these 11 opinions. I will talk about these 3 slides. See, this is where there is, when there are recent injuries to the genitals and other body parts are there, there is evidence of recent sexual intercourse. Partially healed and non-motile, remote. Any local recent injuries are there, but you don't recover spermatozoa, you have to mention there is evidence of recent penetration. Then again, these are the 5, 6, 4, 5, 6, 7. I will not go into this. So you can see when these are the findings, like when local partially healed injuries are there, then there is evidence of remote penetration. But you can see in these 11 opinions, you never write that there is no evidence of any assault or penetration. It is not for you to comment that there is no evidence of any assault or penetration. You can only say whether there is evidence or remote sexual intercourse, recent penetration. Finally, you see, the seventh opinion, when there are no injuries and no spermatozoa recovered from a vagina, which happens in certain cases, then you are in a dilemma what to write. The circumstances and the victim story may be right, but you don't have any evidence either in your examination. But that is when you should not write that there is, absolutely no evidence of any assault. Here comes the opinion number 7, that is, there is no evidence of vaginal penetration, but possibility cannot be ruled out. You never rule out the possibility. So that is how you help the survivor. It is for the police and other circumstantial evidence to prove or disprove, but on from your side you should not negate that there is no evidence of the sexual assault. You can always say that I cannot rule out the possibility though there is no evidence. So 8th, 9th and 10th and 11th is oral and anal intercourse regarding, it is the same as the vaginal except that injuries and semen are recovered from these areas. Again, you can see the opinion 11. When there are no injuries and no spermatozoa recovered from either oral cavity or anal canal, what you say is there is no evidence of oral and anal penetration, but possibility cannot be ruled out. That is important. These 11 opinions is something we all have to be very well versed with while we are writing the final opinion. So you give taking into account everything that I am of the opinion, and you here write one of those 11 opinions. So then again you put your name and signature and seal, and it has to be, copy has to be given to the survivor also, and also victim, free of cost. So the summary, coming to the summary, consent, and I would like to reiterate here that the 2-finger test which was there in our olden reports, and we always used to mention hymen is not intact and it admits 2 fingers, should never be mentioned or should never be done. Hymen or size of vagina, etc., not to be commented upon. Injury documentation, sample collection, and final. This is a summary of what all you have to do. So I think I'll not go into it. It will be a repetition. So this is the resources that we have used. One is Ministry of Health and Family Welfare, Government of India, the guidelines and protocols for medical legal care. And then this is another 50-page book from our government, and also OGSH was part of it. Sexual Assault and Medical Legal Care, a manual for a medical officer. And we also have a video by one of our members. You can check it out in YouTube. With this, I end the presentation. Thank you for a patient hearing. Hope I was clear without confusing. Thank you. Jamuna ma'am, you can summarize.
Yeah, thank you so much, Kiran. I think you have made it very clear, and it was not very lengthy. And I think all of these members who are present here could understand. And I think
we have Dr. Malati here, joined.
Yes,
Malati was
is the
one of the members who did contribute a lot to our state guidelines, and also Madam's video is there on YouTube. I have put it in the last slide.
Can you come on to the screen?
Malati ma'am, can we have
you? Yeah, thank you so much for the acknowledgement.
Show your face, bhai.
I am at home, and then I am planning to do one at MGMH. Probably with the help of the police department and FSL Usmania Medical College this month, because I found a lot of errors because they're not trained and exposed, sensitized rather. So a lot of errors are happening still. What you said, the 2-finger test is being still done. So I think it is a fault from my side for not giving them the sensitization. So this month I have planned, Dr. Kiran, Jamna madam.
The Obgyn module also we are intending to encouraging all the societies to take up, ma'am, from Santa madam's initiative. So I think in the next month or so, all the societies will be completing, including our Hyderabad society.
Yeah, thank you so much. It was very nice, informative. It was a good revision for me too.
Thank you. Thank you.
Actually, I put up in my presentation some of the real case scenarios which we have encountered in the month of May, June, July. And that's how I presented. Maybe if you bring up those real case scenarios without revealing the names, then it is much more easier for anybody to understand.
Yeah, we'll do that.
Maybe.
Malati.
Yeah.
Yes,
Yeah.
Thank you so much. I think now the request is for all these members who have attended this program today to sensitize their members in their societies and bring the number to a higher number, because this is what the vision and mission is, and the effort of making these modules and doing this master training is only to sensitize and orient all our OBGYNs. Now these master trainers who are now today trained as master trainers, they have to take this as a challenge and see that in your society, each and every member is sensitized. And this is what we are expecting. And hopefully we will come through this. And thank you so much. I think if any questions are there, Kiran is there and I'm there, please, you can ask. And we have to take a picture. So all of you have to show your faces now. We want everybody to come onto the screen so that we can take a picture. I love this.
Aruna is there.
Yeah.
I can see. Yeah.
Okay, Kiran, you can take a picture because you are nice at it. You are so perfect at it. Yeah, please, everybody, everyone.
Padmaja is there.
Everyone to come onto the screen, please, so that we can post this picture. Gayatri, Anita, Lalita, Jayashree, all of you, please. And if you have any questions, you can ask. Padmaja, you are also. Your face is not seen.
Joining.
Thank you. Gayatri. Gurudevi.
You can see Lakshmi. I'm on my, I entered through my phone, so I can see only 4 people.
No problem. We all can see you, Padmaja. Yeah. Gayatri, please. Manisha, Jayashree, Lalita. All of you, please come on to the screen. Otherwise, only your names will be seen.
Lakshmi, you have a question?
Yeah, ma'am. Should we follow this format at our place? Because we don't have these formats actually.
Now you
It is there in the guideline.
Yes.
In the, as the Dr. Kiran said, she said about the GOI. It is there. You will have to print it. Tell your HOD. Tell your HOD superintendent.
We got the format through the Sakhi Center and through the police. We got the same format. Isn't it, Aruna? The format they gave at one of I think Aruna can comment.
So
Aruna, unmute.
So I have to download and take the prints, ma'am. This format.
Yes. You just you can get it. You can get it. You have to use it. All these 25 points are to follow this. I think you are safe. And those 11 opinions is what I feel. Many times, some of our colleagues hesitate from writing. If there is, I cannot exclude the possibility. They just write there is no evidence. That doesn't help the victim or survivor in any way.
Yes, ma'am.
I cannot rule out the
Okay.
Yes, Kiran, we got the format from Sakhi Center. Yes. At Vanapati we got. Yes, Kiran. We together we got the format.
From the Sakhi Center, same format. You can try in the Bharosa or Sakhi Centers, or if we have the soft copy, I'll share with you, Prasanna.
Sure, ma'am. Thank you. That will do better, I think.
Instead of sharing format, I think all of us should learn to download and print it out. That is important. Now you can't say, I don't know. You have to do it. That is important. So I think
the other day also we had a dilemma because the DSP called that your medical officer has given like this, and she, as if her statement was saying there is no evidence. I mean of sexual assault. That meaning was there because there was no semen and no injuries. Then we had to redo the statement as I cannot. Yes, it is not there evidence, but I cannot rule out the possibility.
Formats will help you to do it very easily, and you don't have to.
These are important because POXO cases are there. By doing so, I think I want Aruna here to share one case briefly, 2 minutes. One of
yes, Kiran.
Yes, yes. At Nilofar, it happened at Nilofar, madam, one year ago. One of our assistant, she has done a MLC case. She was called to do an MLC case. A 5-year-old girl, she was found abandoned on the road with injuries. Actually, she is a her mother and father, they got separated, and she's living with her father and uncle, paternal brother. And she was found in a bad shape. She was admitted in Nilofar hospital, and our assistant was called to examine her. And she was found, and on examination, there were many injuries are found on her private parts. And she was, and they have got admitted as a batter baby children, some batter baby syndrome like that. They have admitted in Nilofar hospital. But our assistant, she has suspected sexual abuse, and she had registered a case. But her father and even maternal father, paternal uncle, they were denying. They were not interested to do the MLC. So what happened? Our assistant and on duty RMO, they together they have filed a police complaint. But the police people were not taking the complaint because her father is a contractor for supplying vehicles. He was supplying vehicles to the police department. So with his influence, he was not allowing to take the police people were not taking the FIR. But from our assistant and our RMO, they themselves made the police complaint with a lot of difficulty. And even our assistant, she got many threats from the police department not to not take back the complaint. But our assistant, she continued, and they have registered a complaint, and finally inquiry was done, and her uncle, he is found to be culprit. So that all these things have happened. Later, even my baby's mother also, she came back and she has taken the baby, and a lot of tension was there for our assistant. It's a long fight for our assistant.
She was
Later, yes,
felicitated by Swati.
Yes. Later, our assistant and RMO, Dr. Prudvi, our assistant professor Dr. Prudvi, and our RMO Kiranmai, both were felicitated by our by the police commissioner. But there was a lot of tension in the entire case.
Yes,
almost 4 to 5 months. Our assistant suffered a lot of tension.
Yeah, I know they get threat calls, and
yes, madam.
Yeah, I agree with you. It's not that.
Yes, it is that our role is that important, by insisting and not budging. The child was given justice. Finally.
And not only that, Kiran, we have now made that perpetrator worry. I mean, he will not dare to do another
case.
Yes.
Do
so
again.
We have put an end to that fellow by doing
this.
Yes,
by not budging.
Yeah.
I think I was very impressed with this case when Aruna shared. So I thought.
Very nice. Yeah, yes. Aruna, really, it is really. I think worth sharing with others also.
Aruna, anyway, I wanted her to write down, madam. I wanted that girl to write down the entire experience so that we can share with, our other trainers, and this thing we can give as an example, and maybe we can.
Yes, I will.
Yeah. Right. Thanks, Aruna.
So, thank you,
Kiran. Lakshmi Prasanna, you want to say something?
No, ma'am. The same thing. I might.
Doubt is cleared. I think Bashir has posted link to the post test. Please click on that, complete the post test so that you'll get the Dheera Obgyn module certificate.
Ma'am, I had a doubt actually.
Yes, Pratima.
Ma'am, I had attended this trainer of the training program, but I have not got my certificate as yet. So I am attending again today from the start to the end.
Obgyn module?
Yeah.
Okay. Sure. I'll just tell Shriman. I'll just tell Shriman and find out what we can do.
Yeah.
Ma'am,
next.
Yes. Please continue. I'll ask later.
This 10th of September, we are conducting a Dheera training program for our fellow gynecologists and medical officers at Nasik. It will be an offline program. So before that, is it mandatory that we should have the certificate in hand?
No.
No, you have completed. Anyway, just put a mail to the Dheera mail or from your side. I will also put in a word to, the IT person
Yeah,
was.
it is dheera.wow@gmail.com, right, ma'am?
Yes.
Exactly.
Yeah.
You're right.
Okay.
One more
I
thing.
will put the mail. I have already sent the program today to the Dheera team, what we are taking, and I will be putting up for my certificate as well. Thank you, ma'am.
And one more thing we would like to tell you, Pratima, we are
Yes,
not
ma'am.
going to change the modules. The modules will be the same. And that Dheera, whatever the initiative and the write-up is there, you can talk about that. So we are not going to change any module.
Yeah. Yeah, ma'am. We are taking the same modules. Only thing, and we have to play the video of Dr. Shanta Kumari ma'am also in the beginning. Yeah. We will follow all those protocols.
Yeah. Thank you.
Thank you, ma'am.
Just want to give a clarity.
Yeah. No, that's okay. Good.
Yeah,
Thank
Pooja.
you.
My question was actually the same as Dr. Pratama's. It is like I was asking, like for yesterday, when can we expect our certificates? Because it is like I thought this was an automatic process. You fill in the feedback form and you get a certificate. So just wanted a little clarity on that.
I think it takes time because
Okay, ma'am.
inform this to Ajay. And if you have not got it, you can directly email to that dheera.wow@gmail.com and tell that I have attended on so and so day and still I didn't get. And
Okay, ma'am.
probably this is all IT issues, So
Okay, ma'am. I'll wait for 2-3 days, and it maybe in that time we'll get the certificates. Otherwise, I'll mail directly to Dheera. Yeah.
One thing is, it is inconspicuous. Even I have checked. It comes in a, not very, your certificate is so and so, and you have to download it. Many times it so happened that people received, but they could not place it in their mail. I request you
No,
to.
ma'am. I checked my spam and all everything.
No, check by typing Dheera certificate and again check again your mail. But still,
Okay.
mail
Okay,
at
ma'am. I'll do that again. Okay, ma'am. Thank you so much, ma'am.
I think there is some delay in
delay is there.
processing.
Delay is there.
So don't worry about that. Definitely you will get it. And
And
meanwhile, if
even
you
if you
have any
conduct, you can conduct the program.
exactly.
Despite
Even the school programs also, you please
also
conduct.
because the proof is there. You are there in the Zoom and you have completed. And even when you want to do the program, they'll check it and then they'll anyway send the PPTs. They'll ensure that you are completed and then only the PPTs.
Yes, ma'am. How do we access the PPTs? Because I assume that once you get the certificate, then only you can access the
Yeah,
PPTs.
no. You can mention that you have not got your certificate, that you have completed your program and so, and that you intend to do this program and so date and time, and that you get you have to send me the PPTs. Then it becomes the IT person's this thing to check
Okay,
attended and
ma'am.
then completed. Definitely, he'll send you. He'll send you.
Thank you so
Okay.
much, ma'am.
Thank you, ma'am. That was helpful for me too.
Dr. Pratima, where are you from?
I'm from Nasik, ma'am. Nasik OBGY Society. Yeah. We had a talk over phone last
I think
week.
we can come.
Yeah, I think
Yeah.
thank you so much again to all the members.
Yes, we have. That's the reason I was. Sudesh madam is a senior madam. Sudesh Agrawal madam also.
Yes, ma'am. Yes, ma'am.
Good to see you, ma'am. Good evening.
Yeah, it was a good program. Even I would like to conduct the Dheera program both for our faculties and maybe should we go for the schools also, high schools, and should we conduct these?
Ma'am, school module is different. This is different. What you can do? If you
So
have
where do I
you
get the
completed
school
the school
module?
module?
We
Dheera
have a
school.
Sakhi center and I am a
It
nodal
was
officer
done
over there.
yesterday.
Yeah, we have got the Sakhi center and I am
Then you
working
can go ahead
already
with the
as a
Obgyn
nodal officer.
module. This module you can continue. Definitely.
Yes. For
So
schools.
where to get the module for the schools?
No, actually, if your society.
Ma'am, you have to mail.
Yeah.
You can please put the mail ID there, na?
Yeah, okay.
Or write down the one person's mail so whom we can contact if there are any problems.
Yeah, I didn't get, ma'am. Can you repeat?
will you please write down the mail ID and the contact
Sure,
details,
sure.
including phone and mail ID,
Yeah,
so
I'll
that
put the mail ID.
we can ask for some
I'll
help.
put the
Maybe
mail
yours
ID.
only, Dr. Kiran Bhai. It will be good so that we can contact you directly.
You have my number, ma'am. Yeah, sure.
Yeah, I have
I'll
got your
help
number.
whatever I. Yeah, I'm putting it. Dheera mail. I'm putting it here.
Sure.
So let us call it a day then. I think we are holding you for on a Sunday evening.
Ma'am, I'll share it with you. I'm not able to put it in the chat box. I don't know the reason.
Okay. I will write down. I will write down my phone number here. Okay.
Yeah, sure. No, I have your number.
Okay, that is good. Thank you, ma'am.
Thank you so much, everyone.
I'll share it.
I think
Thank you.
We'll close the meeting. Have you taken the picture, Kiran?
Padmaja.
Yeah, I just joined, Kiran. There was some problem. I joined this now.
Can you take the picture, Kiran,
Yes,
please?
Padmaja. Yeah, I'll take once more. Final.
Yes.
Yes.
Thank you.
Thank you.
So, thank you, everyone.
Thank you. Thank you.
Have a nice weekend.
Thank you, ma'am.
Namaste to all.
Namaste, namaste. मिलेंगे फिर.
Pranam.
Pranam.